कभी अपने ब्लड प्रेशर चेक करता है। इसको बंद कर।
You would have to enable the screen sharing option first, sir. It's currently disabled, so we ain't able to share the screen right presently.
See, you share the screen from your side. Am I audible? Can you hear me?
Yes, sir. Good evening, sir.
Good evening, Arvind. कैसे हो?
बस एकदम ठीक है सर. गुड इवनिंग.
तो
हाँ, आप ऑडिबल भी है सर, आप विजिबल भी हैं.
Okay, perfect.
Yes.
And
Yeah.
the organizers, the host, should share the screen and we'll move ahead with time.
Okay, sir. Okay, sir.
I'm not sharing my screen.
Okay.
Perfect.
Just a minute, sir.
Given to me.
कैमरा तो ऑन हो जाएगा, अब जैसी भी सुनाई आ रही है कर लेना.
Hello.
Hello.
Sir, good evening to you, sir. Am I audible, sir?
Yes.
Yes, very much audible.
Yeah. Thank you so much. So I'll be just sharing the screen, sir, from the Cipla house, sir. So I would like to just, before I start sharing my screen for you, sir, I would like to start with the introduction and today's agenda for the meeting, sir. And sir, can I start, sir? Dr. Rajeev Gupta, sir?
Yeah.
Okay, sir. Thank you so much, sir. So first of all, sir, I would like to welcome for this scientific meeting, sir, to all of you. And I would like to start with the introduction of Dr. Rajeev Gupta, sir. And Dr. Rajeev Gupta, sir, is professor and head of cardiology department of Gandhi Medical College and Hamidia Hospital, Bhopal. Dr. Rajeev Gupta, sir, has done his DM from the prestigious institute AIMS Medical College, New Delhi, and sir has started as an exemplary like academic record embellished with the multiples award, fellowship, and oration. He has been conferred with the prestigious BC Roy Oration Award, Professor Austin Doyle Oration, and Professor MC Gupta Oration. He has been offering his services to humanity since more than 3 decades, and he has published more than 91 research in national and international journals. He has been faculty to various national and international societies, and he is associate editor of the prestigious Asian Journal of Experimental Science. And he is a keen researcher and academician with a vision to reduce the coronary artery disease and prevention of metabolic disease in India. And his contribution to the field of cardiology has been highly acclaimed by the medical fraternity and the peoples of Central India. So I'm very excited today and to have like Dr. Rajeev Gupta sir today with us, who is going to moderate today's session for the heart failure, the MRA, a boon in the management of heart failure. So I would like to once again welcome you, Dr. Rajeev Gupta, on the board as a moderator. Equally, I'm very excited to introduce each and every expert panelist, those who are available with us for sharing their expertise on this current topic. I'll start with Dr. Arvind Chauhan. He is a senior consultant physician and associate professor at Gandhi Medical College, Bhopal. And he has been offering his services since last 2 decades and has multiple like publication in national and international journals. And Dr. R.K. Verma is a senior consultant physician and medical specialist at Sihor. And he has received that Excellence Award for his work on humanity by National and International Society Social Agency. And Dr. Alok Pandey is a senior consultant physician currently working at the Navjeevan Multi-Speciality Hospital, Gwalior, and has been offering services since more than 2 decades. And Dr. Rakesh Ghairwar, the senior consultant physicians and assistant professor at GR Medical College, Gwalior. He has been offering his services more than a decade. And also we have Dr. R.K. Singhal with us. He is a young and dynamic consulting physician having expertise in the management of critical like cardiology and currently practicing at Gwalior. And I would like to welcome Dr. Akshat Khandekar. He's a senior consulting physician and geriatric specialist, and he has been offering his services since last 2 decades at the Amar Clinic, Bhopal. And Dr. Prashant Bhagrecha is a senior consultant physician at Vidisha. And Dr. Sanjay Bansal, he's a senior consultant physician clinical at Bansal Clinic, Gwalior. He has been offering his services to mankind since more than 2 decades. So I think with this, I think we are having all the panelists available with us and moderator. I would like to hand over the session to Dr. Rajeev Gupta, sir. And I'll just share my screen, just confirm so that I can start the presentation also. Thank you so much. Hello. Yeah, I would like to request to this technical team, rhythm team, if you can just make me co-host so that I can share my screen. Actually, my name is featuring as an
Am I audible now?
Yeah, rhythm team, can you just yes, sir, you are audible.
Yeah,
Yes, sir.
can you share the
Yes, sir, loud and
screen?
clear.
So please share the screen now.
Yeah, yes, sir. I'm just sharing, sir. Hello. Yeah,
You know,
rhythm team.
it's a real privilege to have such an eminent panelist, and I'm sure today evening would be learning for all of us and also to me when we have Dr. Arvind, Akshat, Prashant, RK, Sanjay, Ramkishan, Rakesh, and Alok. And let us set the ball rolling with talking of congestive heart failure. Please accept my greetings, and I'm sure heart failure today is not really failure. It is a decompensation of the heart, and we really can modulate this term and remove the term failure from heart failure. Let us only talk of disease of the heart, decompensation, and how do we maintain the hemodynamic status. It is not really a disease only of the heart, it is a neurohormonal disease. And when we have drugs like the MRAs and the ARNIs, we can tackle this neurohormonal imbalance and bring back the functioning to our advantage. So please share the screen so we go ahead.
Sir, I'm just sharing the screen. Actually, I just requested the technical team to make me co-host. Yes,
Okay.
sir. Yeah.
So there were days when we talked of heart failure and we talked of inotropic drugs. We talked of digoxin, and we learned with time that digoxin really does not change the morbidity and mortality. Then we talked of unloading the wagon by removing the extra fluid, the diuretics. And again, we learned that it is not only the extra fluid when we remove, but also we have to change the after load. We learned about the vasodilators, the peripheral drugs which reduce the vascular resistance and came to our advantage and salvage was the ACE inhibitors, the ARVs. But realizing that all these do not change the neurohormonal component, came the drugs like the mineral corticoid receptor antagonist, and it really showed in the EPICUS and the RAILS trial that it reduces the mortality and it also changes the course of the disease. And finally, we now are with the ARNI era, where we have to realize that ARNI with MRA, with beta blockers, would help us in addition to anticoagulants and also using mechanical receptor drugs, maybe the CRTs to take care of the filling of the ventricles. And finally, all of them together, hand in hand, would change the course of the disease. Next slide. Next slide. Next slide. So where do we place today MRAs in the heart failure management? And should we really be worried about hyperkalemia, which is a known apprehension when we are using MRAs? And all the same, when we combine this with an ACE, ARB, or an ARNI, hyperkalemia really is disturbing. So let us try, next slide, try awareness amongst us physicians and reduce the course of the disease. And all of you would agree that heart failure today is not a disease per se. It is a creation of our own improvement. When we try and improve myocardial infarction, when we do angioplasties, when we do bypass surgery, we make the patient live longer with the disease. And here comes the role of heart failure. And the prevalence would then increase with age and rise more than 10% among people who are more than 70 of age, who had a myocardial infarction at the age of 50, who had an angioplasty at the age of 60, maybe bypass at the age of 70s, and now are living with a diseased heart muscle because of our action. Next slide. So let us begin with the eminent panelist. We have Dr. Arvind Chauhan, who is a colleague of mine and who is in the management of heart failure and geriatric patients. Arvind, we want to learn from you what percentage of heart failure patients approach to you in NYSA stage 2 or more, and how many heart failure patients really go undiagnosed in our situation, in our setting in India, at the early stage. And if we know that if we can take care and diagnose these patients at an early stage, we would do better. So your comments, Arvind, please. Yeah, please unmute.
Hello, am I audible?
Yeah. Now you're audible.
Sir, we have seen our clinical practice that in patient who is having the congestive cardiac failure, the prominent features with the congestive cardiac failure, about 10 to 15% of the patient of NYHA second and third degree, they are undiagnosed.
Okay, so you'd say the milder the symptoms are,
Yes, sir.
there are chances of missing this bus. The chances of missing because patient really would not be able to tell you the true symptoms. He would say, beating around the bush, he had some symptoms, and he would correlate with, we agree. So how many patients, these patients, when we miss, what really are the apprehensions in your mind? Because if we pick up early, probably we do better.
Suppose if the patient came with our clinical setting, and if he is having the mild sort of dyspnea, palpitation, in pre-existing heart disease, we can think of the early features of the congestive cardiac failure. So the symptoms which are very mild, but we can think of the initial phase of congestive cardiac failure. So it is important to pick up these symptoms as far as the early diagnosis is concerned.
So you have pointed out very crisply that picking up early is so important. And going a step ahead, when we talk of the stages of heart failure and the gradings, the ABC, there could be a disease but no symptoms or no failure. And probably we should pick up here these patients. Now we have Dr. Akshat Khandekar, who is again an eminent physician.
Good evening, sir.
Again, Akshat, welcome. And we would like to learn from you. What are the diagnostic tools we have, and how do you use these tools? And the prognostic tools, because we know that mild will have a better long-term effect, and the severe they are, the prognosis would become better. So how do you pick up these diagnostic tools and prognostic tools to the advantage of heart failure patients and to the advantage of the treating physician?
Right, sir. As Arvind sir rightly mentioned, that if patients are picked up at stage A or stage B, which are no risk factors and with slight risk factors, so we could do wonders. As you have rightly mentioned that it is a decompensated state. So once we have talked about decompensated state, it's an amalgamation of so many things. So it's a final common pathway, which we call as heart failure. As far as diagnostic techniques are concerned, once the patient has presented, and most commonly they have exertional dyspnea and palpitation. So our basic tests, what we do most commonly, ECG, electrolytes, liver panel, these all tests. Apart from it, ECG gives us a lot of clues, as for example, wide QRS, chamber and enlargement, which may give us a clue to go for an echo. Once the echo is done, we can ascertain that whether there is a structural abnormality or there is a chamber and enlargement, and most effectively the pinpoint thing what we see is that is the ejection fraction. So we could easily grade in as in what stage the patient has come to. In milder form, as sir rightly pointed out, because since the body, our human body is so good in adaptations, so it adapts so well that they miss the buzz that I am having such an important disease. So in fact, to concentrate on heart failure, we have to concentrate on the root of the things. As far as the prognostic markers are concerned, at the first instant, if the patient is having such an, he or she is having risk factors pertaining to coronary artery disease, diabetes, hypertension, not least to say that if it is uncontrolled, we should go for a very biochemical test, what is known as either BNP or anti-proBNP. That gives us a clue. That gives us a clue whether which stage is the patient is. Recently, I got two cases, probably 80, 85 years old. They were not aware. They were anemic. They were not aware, and their BNP rose to 10,000 and 15,000. But still, they were adapting and by the human body itself. So I think, and as it is known fact that the BNP goes down once the cardiac muscle comes into compensation. So in my view, these diagnostic tests should be run for all the patients, irrespective of the cost, because ultimately we are saving a lot of cost from the ICUs if we pick them up early.
So, see, we really appreciate the way you approach the whole thing. That simple test, electrolytes, would tell us the associations of heart failure. And then you beautifully told us that prognostication of these cases by identifying the BNP level and to one extent even troponin level will help us quantifying the amount of damage. And don't go on the cost of these tests, because early picking, you are probably saving a lot of money in the long term by preventing damage. So thank you so much. I really appreciate that. Next slide, please. So, there are so many updates coming, beginning from heart failure, the ACC, the European Heart Society. But what I really feel is that we should not become slaves to these guidelines or these consensus reports. We should design the guidelines in our situation, in our setting, in our patients. And caution should be there when we exercise, when MRA is used. Always monitor, as Dr. Akshay told us, the serum potassium. A slight change in the serum potassium above 50 can do a lot of damage. And in cases of renal impairment, if the eGFR is less than 30, or if the creatinine is more than 2.5 in men and more than 2 in women, probably we are dealing with cardiorenal syndrome, and our MRA, our drug, probably would worsen this potassium catastrophe. Next slide. Next slide. So we have Dr. Prashant Bagrecha, who is managing heart failures at the mini level and at the tertiary level also. He has a lot of references of heart failure, and we appreciate his expertise. Can I ask him, are these parameters, potassium, creatinine, eGFR, tested before routinely and after initiating MRA? And how long, how frequently, how often? Or you rely more on the associated findings? Because saying this, that get these tests repeated probably would sound easy, but in a set of patients, it may not be very easy. Prashant, your opinion, please. Do we have Prashant with us? Can I request Dr. R.K. Verma, if he's with us, to take up this question? Am I audible? Yeah,
Yes.
Dr. R.K. Verma. Yeah,
Yes, sir.
We
Sir, we are
understand.
treating such patient because we are at district level,
Yes.
and this eGFR and potassium and creatinine level, they are very important parameter for us, because nowadays these investigations are available in district hospital. So we are treating these patients by these parameters.
I appreciate your straightforward answer that at the district hospital. And but let me tell you, Dr. R.K., you are a specialist and you also are a cardiologist. We know your.
Sir, I am treating all sort of patients.
I know. I worked with you at some stage. So I appreciate the way you approach this problem, that we should be doing it more often. Thank you. Can we have the next slide, please? Next slide. Yeah.
Next. This is the algorithm.
Hello. Yeah, good evening. I think we have lost like Dr. Rajeev Gupta sir in between due to maybe some technical error. I think he would be connecting soon. Yeah.
नमस्कार सर, तो कैसे हैं?
Hello.
सर
Yeah.
आ गए, चलिए।
Am I back with you?
Yes, yes, sir.
Right, yes sir, audible है।
Okay. So did I miss something in between? You carried on the conversation, or I start again?
Yes, you can start from the next slide, sir.
Okay. So MRI is recommended to reduce the risk
Next.
of heart failure, hospitalization, and death. But MRA may be considered to reduce the risk of hospital or even death. This is a class 2B indication, but class 1 indication it reduces. So next slide, please. And when we talk of combination of ARNI, beta blockers, MRAs, and SGLT2, all of us are now using SGLT2 in heart failure patients, even in a non-diabetic. And the journey is long, but we have to realize that of the 4 drugs, which one we choose at what stage of heart failure. Next slide. So my question would be to Dr. Sanjay, who is an eminent physician and lot of patients of heart failure, that in what percentage of patients you use MRA? Because this confusing data and guidelines of using ARNI, SGLT2, beta blockers. So where would you place MRA in heart failure management? Sanjay, would you enlighten us, please? Dr. Sanjay with us? Am I audible?
Yes, sir, you are audible, sir. I think he has dropped out, I think, for the moment.
Don't worry.
Yeah.
We have many people whom we can learn. Is Dr. Ramkishan Singhal with us from Gwalior?
Yes,
Dr. Rakesh? Dr. Rakesh? Rakesh is there, yes. So, Rakesh, we want to learn from you where we should be using MRA in this subgroup of patients. Yes, please go ahead. Rakesh? Dr. Alok is there with us. Am I audible, the organizers, the host?
Yes, sir, you are perfectly audible, sir.
So whom do we ask? We have Dr. Sanjay, Ramkishan, Rakesh, or Alok with us, or we can wait for their answer and go back to Arvind and get a very crisp answer and opinion of Akshat and Prashant and RK then. Arvind, would you comment?
Exactly. Hello, am I audible,
Yeah.
sir?
Yeah, very clear.
Exactly, percentage wise we can comment on what percentage we can use MRA, but definitely as far as the heart failure management is concerned, the MRA along with the ACE inhibitors and the other beta blockers, it is very in a frequent use, like
Okay.
spironolactone or eplerenone. Both drugs we are using since very long time. So exactly percentage wise, sir, you can tell regarding the percentage.
Okay.
Because,
Okay.
yes, sir.
See, Arvind told us very clearly that in a subgroup of patients, it would depend on the individual choice of whether we use beta blockers, MRA, ARNI, or SGLT2. For a diabetic, we have no confusion that we are using SGLT2. For a patient who has a high renin clinical situation, their ARNI would be the first choice. And having learned that the atrial natriuretic peptide is a protective hormone, and we should prevent the destruction, we should allow the good things to continue, the bad things to vanish. So we want ACE inhibition or ARBs to prevent the angiotensin 2, and the good things that the A and P should not be destroyed by the neprilysin. So we allow neprilysin inhibitor to prevent the degradation. Now MRAs, we know that they are diuretic, they change the LV remodeling, they change the effect in the left ventricular myocardium, they prevent the apoptosis, they prevent the fibrosis. So probably you're right that combining spironolactone or eplerenone in these situations is to the advantage, and we should be combining MRA in all these patients.
Sir, is there any specific indication for using the eplerenone or this another group?
No, I agree.
Spironolactone or eplerenone.
Yeah, the EFICIS study has told us that the long-term reduction in mortality is much superior if we use eplerenone as compared to spironolactone. So given the choice, the spironolactone would always be inferior to eplerenone. Now, when we compare this eplerenone with an ARNI, you can always use eplerenone in combination with an ARNI. So you can always use MRA eplerenone in combination with SGLT2, and beta blockers any day is a very good friend for all of these drugs. So MRA in combination to whatever you eat is always sort of an icing in the cake, and we should be using MRA minus the risk of serum potassium getting elevated, and which all of us agree that we would be getting in serum potassium at the desired moment of time. So MRA is superior.
Sir, at what level of serum potassium level or hyperkalemia we have to stop using these MRAs?
Yeah.
Any particular level?
Yeah, I really appreciate that question, and let me tell you, all your few so senior physicians know that a serum potassium 5.1, 2, 3, 4 may not be hazardous if we are taking care of hydration, if we are maintaining the EGFR, and if the ECG does not show hyperkalemia. So to my mind, if we are monitoring the ECG and we are not getting the bad things of hyperkalemia, a slight rise of potassium should be modulated, can be tolerated, and would not produce a disadvantage. Now, moving ahead to the next question, when do we consider starting MRAs in patient with heart failure along with ACE inhibitor? I think part of the answer is already clear, that when should be combined with an AC and ARB, and when should be combined with a beta blocker, and all of these close friends, the beta blockers, ARNIs, ARNs, SGLT2s are hand in hand to the advantage. So may I request Dr. Akshat again, you have told us very clearly about the potassium. We want a crisp answer. When do you consider starting MRAs with ARB, ACV, or beta blockers?
Right.
Akshat, please.
Right, sir. As far as I am concerned, I would like to start MRA as soon as possible, probably by day 3 or day 4 of it. Why? Because initially when we go for ACE inhibitors or ARB, we are targeting the RAS neurohormonal modulation. But sometimes what happens, it basically escapes after day 2 or day 3, because we cannot start it off on a high dose. So we have to start low and go slow. So we expect that by day 2 or day 3 it comes up. So by day 3 if we add, so that both will work synergistically to antagonize aldosterone.
Okay. So Akshat, I appreciate your final answer. Slow, go slow and low. So low and go slow will avoid all these risks in our mind and help the patient. Thank you so much. Can I request for the next slide from the host? We have been talking of aldosterone receptor antagonist, but we also know giving the aldosterone antagonist, the aldosterone continues to rise. And this bad aldosterone, the mechanism is known as aldosterone escape. As we earlier had seen, the angiotensin escape when we used an ACE inhibitor, and that brought to the era of the quinlanapillar or the trendepril and ARBs. So this aldosterone escape needs a word of consideration, because the importance of time of initiation of mineralocorticoid receptor antagonist on the risk of mortality in these particular subgroup of patients, and probably here lies the importance of selecting aplerenone over spironolactone. Next slide, please. So how do we compare spironolactone and aplerenone in terms of the aldosterone escape, and secondly, on the improvement of the LV systolic dysfunction, and the methodology, which could be many, as our speakers have told us, but do we really see the diastolic dysfunction, the systolic dysfunction, the left ventricular ejection fraction alone, or also see the left ventricular ejection time? Because we know the pre-ejection period is probably useless. It does not convey anything to the LV ejection. It only tells us that the pressures within the ventricles are changing. So what parameters, the fractional shorting, the tissue Doppler imaging, or other parameters would help us in truly assessing the LV systolic dysfunction? Next slide. And here comes the question, when do you prefer using aplerenone and spironolactone? Any specific patient profile? You go with the ejection fraction, you go with the serum potassium, or it is your personal experience? Because we have discussed that the guidelines, the consensus statement may make you slave for themselves, but you are masters in your field. And how do we learn to use a drug in a particular patient? Do we have Prashant with us, or Sanjay, Ramkishan, Rakesh, or Alok with us? Anyone?
We have like Dr. Verma is there, so we have Dr. Verma available.
Oh, perfect, perfect. The best choice. Can I request Dr. Verma to please enlighten us? Dr. RK from COS.
Sir, in clinical practice, in our level, in district level, sir, we don't have echocardiography, color Doppler.
Perfect.
So we prefer spironolactone, sir. We use spironolactone, not aplerenone, and we are also having nowadays we are trying to go for echo and color Doppler, so we can use aplerenone.
Okay, so we take this point very vehemently, that in one hand we have the biochemical markers, the second hand we have the ECG, the third hand we have the echo, and should we knit them all together to our advantage? And here I would agree that you have started using aplerenone, and I'm sure with the experience of all of us, aplerenone is doing as safely as spironolactone. It is not producing any miseries in terms of hyperkalemia, provided we maintain the volume. So I appreciate that we have started using.
Let's try, sir. We will try in some tests.
No, I know, and it would be with the safety concern, of course. So thank you. And Apleron, all of us agree, will be a molecule we would be using more often in the future. Can we have the next slide, please? So then, to our mind, if we are using both the drugs, then how would you modulate in terms of the dose adjustment, and how would you escalate the dose from 25 milligram to 50 milligram, or would we be concerned with the eGFR when it falls from 50 to 30, or would it be that we look at the serum potassium? And probably the answer has been already given by the eminent panelists that eGFR is one factor, potassium is second factor, but the clinical improvement probably would take upper hand because we have enough recommendations that when the serum potassium is less than 6, initiate a potassium binder and reintroduce, continue MRA. So MRA should not be stopped because it is the effect rather than a side effect. So if you have a rising potassium, probably you are dealing with the effective mineraloid receptor antagonist rather than the side effect of these drugs. And this we have seen in the era of digoxin also. You have ST depression, you have some arrhythmias, and you continue digoxin. You have yellow vision and you continue digoxin because this was an effect and not an adverse or side effect. So next slide, please. Next slide. So then what is the preferred dose and how is the dose titration done, having been convincing ourselves that a minor rise of the parameters will not impedance us to use the drugs. We are confident with the drugs, we know what to do, and we know that even if this potassium rises, we'll use potassium binders. So can I have one of the panelists, if they are there, Prashant, Sanjay, Ramkishan, Rakesh, or Alok with us, if they have joined?
So Dr. Singhal, I can see Dr. Singhal is there.
Oh,
sir.
no, perfect. We were looking for Dr. Singhal because we know his expertise in this. Dr. Ramkishan Singhal, would you comment on the preferred dose and what way you modulate?
Yes, sir. Good evening, sir. Actually, now given practice, what we start from is and we see the response, how the patient responds. Once the patient starts responding, the dose, if patient is resistant or not responding to the 100 per day, we can go. But when we all look at the potassium, serum potassium level must be monitored closely when we giving we are giving MRA. So that should be keep in our mind when we are titrating or up titration is going, or we are doing up titration for the dose. If patient starts responding, we can maintain the MRA at the optimum dose and we can continue with that. Sir. Hello.
Yes, sir, you are audible, sir. I think sir has.
Yes, I think sir. Yes.
Due to some technical problems, sir will be connecting soon, sir.
Okay.
Yeah. Am I back with you again?
Yes, sir. Yes, sir.
Yeah. Dr. Ram, I'm very sorry. I just missed your important message. Could you repeat it, please?
Sir, sure. Actually, sir, in our clinical practice, what we are doing is starting our MRA dose is from 50 to 100 milligram per day. And we wait to see the response, how patient responds to these doses. If the patient is not responding, then we can titrate the dose to up to maximum 400 milligram per day. Spironolactone is nicely and easily available in the market, but Apleron is always better than spironolactone, as I feel in practice. So whatever is available, if patients are responding, we can maintain the dose to the optimum level to 100 milligram per day. I think that is the usually optimum level for which patient starts responding.
Perfect. Your message is so clear that don't worry about the dose. Start and build up this dose and go to the maximum dose. And the advantage would come in an escalating way. You increase the dose, the maximum tolerable dose, the maximum effective dose, and you will see the results in the ejection fraction and the parameters. The BNP would come down and you would have a reduction in the. So don't worry about the dose. Thank you. Very clear.
Yes, sir.
Next slide. So coming back to the concern, as all of us have again and again, that the prevalence of hyperkalemia was 9.3%, out of which 54% was truly related to MRA. So if we say that MRA is not predicting hyperkalemia, yeah. So if you say that MRA is not producing hyperkalemia, we are trying to escape from the allegation. So if you see the study and see that contribution of MRA in hyperkalemia, Epleron was 46%. In 746 patients, that is around 9%. So don't worry about this hyperkalemia. We know it is because of MRA, but we also know it is a reversible hyperkalemia. Next slide. So can we go back to one of the panelists again? What percentage of heart failure patients on MRA develop hyperkalemia in your clinical practice? And this is a real world question, because we go back and rely more on your experience. And do they require discontinuation, hyperkalemia because of MRA, or you have modalities to manage this hyperkalemia without going in the miseries of hyperkalemia? So have we one of the panelists whom we missed, Prashant, Sanjay, Rakesh or Alok, who have joined us, or go back to our first panelist? Is Prashant with us? Sanjay, Rakesh, Alok? We'll go back to Arvind for a very brief comment.
Good evening.
And,
Yes, sir.
and have a comment
Sir,
of Akshat also, and RK and Ram on this.
Actually, in heart failure patient, we are very frequently using the MRA. But as far as the hyperkalemia, up to that level, that we can stop using this drug MRA, is not very frequent.
Okay.
So I don't think, yes, sir. It is.
Yeah, I agree. I agree that even if it produces, you just monitor and
Yes,
don't be apprehensive. Yeah, Akshat, a very brief comment in maybe 30 seconds.
Yes, sir. I would second Arvind, sir. Why? Because even if it is exceeding the levels, we have mild, moderate, and severe hyperkalemia.
Yes,
so
perfect.
Reduce the dose by 50%, and that's it.
So don't worry. RK, your comment, Dr. RK Verma.
Yes, sir.
Ram, yes, RK is there.
I think, sir, very few patients develop hyperkalemia in my clinical practice. Very few patients, sir. And we definitely manage by different modality. Because of we use in our district place, spinal electron is available. Epleron rarely available, sir. That's why we use spinal.
We are not afraid of.
We don't come across hyperkalemia patient.
Ram, your
we come across only 2 to 5% patient.
Yes, sir. Yes, sir. As you already said, sir, if the potassium level goes up to the 6, then we don't need to bother about the potassium level. We can just add the potassium binder and continue with the MRAs until there is moderate or severe hyperkalemia, where we have to give some active intervention.
So all the 4 panelists, and even I am with them, behind them, that don't worry about hyperkalemia. Monitor them, monitor the eGFR, and if it is more than 30 and your potassium, even if it is biochemically elevated and not producing an electrocardiographic change, continue with your MRA, and you have safely the potassium binders in your hand. So don't worry about it. It is an effect and not a side effect. Next slide, please. So the timing of Epleron would now come in play, and initiation and outcomes in the patient with heart failure. And let us look at the Ephesus study. And this is what we have been talking of, that we now are at an advantage of having the Ephesus data. The next slide. Next slide. So see how clearly this graph tells us the 31% reduction in all-cause mortality in patients with heart failure. And we have a subset of post-AMI patients where we compared eplerenone with placebo and initiated before 7 days versus after. So as somebody told us, begin slowly, begin early, continue slowly and monitor them. And if you continue, then after 2 years, you will see that if you start eplerenone earlier, you have more benefits in terms of better survival, the upper graph as compared to placebo or eplerenone later. So it's not eplerenone alone. The upper graph tells us earlier, longer, better results. And when we see the eplerenone earlier data again, the survival is longer in post-MI patients. So we have a clear data from the Ephesus. Earlier eplerenone, longer eplerenone, tolerated eplerenone will give us patients with better survival. Next slide, please. So again, we will have to go back on our expert panel that in clinical practice, how early an MRI is initiated in the management of heart failure. All the 4 panelists have told us the patient will try to ignore, he may not be aware. We have the biochemical test. Somebody has told us BNP will come at an advantage of prognosis. And where would we start MRA now? So can I ask all the panelists to please give a very short answer? Ram, you begin.
Yes, sir. In our clinical practice, actually, as soon as the patient came to us with the features of heart failure, we can start the MRA at our first contact with the patient. As it is going to help the patient in any way. Yes, sir.
Right. This increases our confidence of early starting. Can I go back to Dr. RK for a crisp comment again? Prashant?
So definitely we started first contact MRA.
See, so both
we
of us agree.
Don't worry about hyperkalemia and other things.
Don't worry.
We should start as early as possible.
Okay. It increases our confidence that you people are starting it, so we can also do with monitoring. Akshat and Arvind, very crisp comment. Akshat.
Yes, sir. I would like to start it on day 2 or day 3. Let the ACE or ARB inhibitors do their job.
Oh, great. So anyway, it has to be below 7 days, and you have gone to the extent of second day, and I really appreciate the way you told us. Arvind?
Yes, sir. As early as possible.
Okay.
After second or third day, we can start in post-MI patient also.
So all of us agree that early the better.
Yes, sir.
Next slide, please. So now we come to the very important question of class 1, where patient has risk factors, patient has a substrate, patient has some hidden myocardial damage, and still he says I'm not symptomatic. And also this indication would carry a long way in the heart failure reduced ejection fraction class 1 therapy. Next slide. So at what stage of heart failure, diuretics and MRA both are needed. You have told us clearly that eplerenone or MRA for that matter will help if we started early. Should we combine with a diuretic in the early stage, because this could be a patient which has no volume overload. But no volume overload clinically does not mean that his LA pressure is not high, his pulmonary venous congestion is not high. He could be asymptomatic, still having some volume overload. So, and the next question I will combine with this. What is the preferred choice here? Eplerenone alone or if we want to combine with a diuretic. We know that this is stage 1. We know there is no dyspnea, but we want to give a diuretic. Or spironolactone alone with a diuretic. So 2 things. When do we begin diuretic and what combination? Again, I go back to Dr. Arvind and then move on to the...
Sir, I think we have to individualize the patient.
Okay.
If there is a comorbidities like post-MI patient having diabetes and their ejection fraction is low, we can start with the eplerenone plus torsemide or spironolactone plus torsemide.
Okay. So, taken the message that reduce the ejection fraction, it would be safe.
Yes.
Akshat, your comments?
So, like our previous panelist said, we need to classify them as whether they are wet or dry. So if it is wet, the diuretic would help them. If it's dry, then only eplerenone would.
Okay. So, decide about the volume overload, the wet lungs, and then decide. RK, your comment, please. Dr. RK Verma. Dr. Ram.
Yes, sir. Yes, sir. The doctor said actually said that if the patient is wet, has signs of fluid overload, then definitely we need to combine MRAs with diuretics. But if they are dry, then we can go along with MRAs.
Okay. So this is the time when I should thank the host for choosing so good a panelist. They give clear message and I appreciate. Thank you so much. Next slide, please. A common question. In your practice, any other indication apart from heart failure where MRA is used? And what scientific initiatives would we suggest to the host for increasing awareness among practitioners? Because, MRAs need to be propagated. The louder the noise, the better it is accepted. And the message should go at the lower level. We are experts. You all are specialists and you know what to do, what not to do. But the common practitioner, the general practitioner, this message should go. Because when you write a prescription and there's some other doctor, he would say, well, I'm not in favor, so you can as well stop. This trend probably will have to change, that don't stop a drug which in the long term will reduce the survival. So very crisp answer from all the 4. Arvind?
I think we can use the MRA other than the cardiac condition. There is a volume overload, like in alcoholic liver disease, where there is a severe ascites or nephrotic syndrome, and many other conditions. We can use the MRA.
So non-alcoholic fatty liver disease and alcoholic fatty liver disease, both we are using. And again, we are masters in managing potassium now, so we are not apprehensive. Akshat?
Sir, in essential hypertension as well, it can be used.
So we have more indications coming. Hypertension respond very well to mineral receptor antagonist.
Right, and it has an off-label indication for hirsutism as well.
Hirsutism, perfect. So,
and age-old.
Yeah, perfect.
Age-old.
Dr.
Right, RK. Right.
Okay, Dr. RK Verma, please.
Yes, sir. I use in cirrhosis of liver. And in alcoholic cirrhosis, I use in ascites frequently.
Perfect. Dr. Ram?
Yes, sir. Decompensated liver diseases or heart failure, apart from that, we can nephrotic syndrome also.
So if you have ascites, we have been using it in Budd-Chiari syndrome. We have been using in pulmonary arterial hypertension also at situations. And all of us agree to these few indications. And I would request the host to take up these indications in propagating to all of us, that we be confident in using, and we would have very rich dividends. Yeah. So how do I thank my co-panelist? I'm wiser, as I told you when I knew that I'm interacting with you. Thank you so much. And I would request the host to bring more occasions when we have such eminent panelists and very, very crisp discussion, very clear messages. Thank you so much.
Thank you, sir. Thank you very much.
Final comment from
Leisure was entirely ours.
Yeah, Arvind.
Leisure was entirely ours to hear you out. Thank you.
Sir, excellent talk, sir, from your side, and we have a very good discussions with MRAs. And
Okay.
thank you all team members of CIPLA.
Akshat, your comment?
Yes, sir. The pleasure was entirely mine, and it's an honor to share a virtual stage with all such eminent speakers and experts. And it was an honor to hear it. Thank you.
Thank you. Dr. R.K. Verma, please.
Thank you very much, sir. Sir, your guidance and excellent view on heart failure. Dr. Arvind Chauhan, also my colleague, and other doctors also. Today, we are
I am also your
definitely
colleague. I am
enlightened.
also your colleague. We have worked for some time in Gandhi Medical College about 15 years back.
Yes.
Yeah, Dr. Ram.
Yes, sir. Thank you so much, sir. Actually, there are so many seniors with me in this panel, and I'm definitely going to learn something from this. And thanks to the CIPLA team for joining me as a member. And definitely, it's a good discussion, a very crisp discussion, especially with Dr. Chauhan sir and Rajeev sir. Thank you so much.
So we welcome you in Bhopal, and hope the COVID relaxations come up, and let us pray to God that we are not in the same trip. Thank you so much. Do we have any other panelists joining us, or we hand over to the host?
I think.
Thank you.
I think
I'm handing over to the host.
Sir, thank you so much. I think it was a wonderful discussion and insightful, interactive session, more often discussion, sir. And we all are equally, sir, like honored and privileged to have like Dr. Rajeev Gupta today with us to share his expertise basically on the topic and agenda which was being offered. And moreover, sir, equally all the participant expert panelists who has shared their clinical experience. This has given a lot of insight to CIPLA as a team, to the medical team. I think the guidance in the last that you have given, these are the different indications, which we will have to explore, particularly at the physician level. So this point is really taken, sir, and thanks for this guidance, sir. And
Thank
would
you
like
so
to continue such event in future as well, sir, because we have also seen into the market, because into the 4 pillars which is being indicated for heart failure management, like MRA is somewhere neglected because of talk of the town is used to be ARNI, SGLT2 and beta blocker to some extent. So we have taken this initiative, sir. Thank you so much, sir.
Thank you. Bye-bye.
Thanks for your time, sir. Good night, sir.
Okay, good night. Good night, sir.
Thank you. See you.
Thank you, sir.
I'm leaving. Thank you.
Thank you, sir. Good night, sir.